Karen
Thank
Barnett.
you. Thanks. Hi, everybody. And I'm very grateful to be here with all these awesome speakers, particularly Lorimer Mosley, who's like my all-time mentor, because I just love pain science. About a year ago, a little over a year ago, when I met Rajam at a course, and then she was super excited I'm local, and I do something a little bit different related to pain science, and so she called me up and said, Cara, do you want to speak? Lorimer Mosley's coming. Would you like to speak? I said, of course. That's awesome. What a great opportunity. And then I got off the phone. It's like, oh my God, what the hell am I doing? So I practice a little self-compassion. I do know a few things about pain here, and I have a very novel approach because of where I'm coming from, so I'm glad to be here. And so I'm going to talk about how we basically treat patients in an HMO environment. And there's no two ways about it. In an HMO, big organization, work for Kaiser, a lot of it's about saving money, and still at the same time trying to provide quality care for these patients. Pain patients don't necessarily...
HMO? What's that? For non-Americans?
Oh, I'm sorry, health managed organization.
Sorry?
A health management organization. Sorry.
They're from the other side of the pond.
Yeah. So, okay. So traditional HMO, just to say, it's a large organization where we generally have a lot of integrations. There are a lot of specialties that work together. A lot of our documentation is online, so we can communicate well with people and other providers, which would be very helpful. But sometimes patients can get lost. And a chronic pain patient doesn't necessarily fit in the traditional medical mold of an HMO. And part of that is because these patients, they continue to seek care, and so they tend to skip around to multiple different specialty departments. They continue to request more imaging, and they're continuing to seek answers to their pain until someone will sit them down and say, hey, maybe this is something a little bit more beyond structure here. The problem with that is that it starts to add up. These pain patients cost a lot of money. So over $600 billion per year, this was from 2010, for the cost of pain. The number of patients seeking care, I think, is increasing due to the Affordable Care Act. Also, just in San Diego alone, in Kaiser, the Kaiser that I work for, there's over 500,000 members just in San Diego. And over, I think, 50,000 of those folks have a chronic pain diagnosis or they're on opiate medication. It's a lot. And we're a small department. So it's a lot of work. So I think really, though, it's easy to blame the large organization for problems, but I think we need to really reflect on what we are doing as providers. I think the problem begins with us, or it can end with us. So before I talk about what I do specifically at Kaiser in terms of participating in a multidisciplinary program, I want to talk about the communication. And I know everyone's going to touch on this. A lot of the speakers are going to touch on this in a little different way, but I think we're all trying to say the same message. I was reading an interesting review article written by Sarah Edmond and Francis Keefe. And they were highlighting a study that examined the effects of validation on pain-related thoughts and feelings. And basically, how I was educated is that the operant conditioning model, if someone comes into you and they have a lot of pain-related behavior, you don't necessarily encourage that, right? Kind of change the subject. You don't want to reinforce those behaviors. But what they're finding now through some of these studies of validation is that if you just take a moment and you sit down with them, their levels of validation, were not necessarily related to reports of pain, anxiety, and depression. But if you did validate, these patients were a little less angry, and a little less frustrated, and a little less worried. I don't know about you guys, but when my patients come in to see me, they're usually pretty upset. because they've already been through many different providers, and no one has really tried to explain what's actually going on with their nervous system. So some examples of validation would be just basically simply nodding and agreeing with the patient when they're describing their symptoms. Or they might say, I hurt more today. And so you can just kind of, so I understand that you're feeling worse. That must be frustrating, kind of identifying. Articulating the unverbalized. I can't get anything done. I have pain all the time. And I'll say, sounds like you're frustrated. I'm very sorry. So taking a little bit of time in the very beginning to just validate their symptoms, sometimes we'll kind of break down the wall, and then they might be more receptive to listen to what the pain science has to offer. I have a strange habit of collecting body charts, especially the really good ones. And I particularly like this one. You could see most of the body is shaded in. And this woman had even a schematic. So she was nice enough to break out her highlighter and for the worst and most constant areas. Now, how many people in here have seen a body chart like that? Probably quite a few of you guys. And think, oh my gosh, this patient's 20 minutes late. My next patient, 30 minutes. I see this body chart. Where am I going to start with this patient, right? These are my patients every day. So you have to take a little bit of a different approach with these folks. You can't say, I'm going to regionalize this pain. I'm going to look only at the shoulder or the spine, or where is your worst pain today? Because I think this patient is actually screaming validation. I need validation. So in this particular instance, I might just sit with them for 20, 30 minutes and just say, tell me what's going on. Not trying to pretend to be a psychologist, but sometimes you actually have to have that where they can feel like they can disclose themselves, and that encourages them to engage and problem solve together. How else is chronic pain perpetuated in the traditional health environment? Well, has anyone ever seen the movie The Matrix? Raise your hand if you guys seen the movie The Matrix. I kind of want to get a knife. I love that movie. And if you guys haven't seen it, you should. If you have seen it, you should see it again. And I want you to think about the Matrix being like the biomedical model. Okay? Because I see a lot of similarities, and sometimes I feel like I'm in the Matrix at all times. And I think the biomedical approach is everywhere. Even now in this very room, you can see it when you look around your medical offices. See those spinal models, the anatomy charts. You can feel it when you talk to your orthopedic manual therapist or your orthopedic surgeon, or when you're interpreting those imaging results for patients. It's a world that has been pulled over the eyes of the chronically sensitized patients to blind them from the truth. The truth that they have become a slave of the structural world of medicine. It is a world that teaches them there is no hope for cure for chronic pain as long as your patients have structural faults. It's a philosophy that if they do not get better with the biomedical approach to care, these patients have to live with their pain and never complain, because nothing more can be done. Now that's kind of the biomedical approach. I think the biopsychosocial approach, like we've already touched upon, can provide more hope and insight for these patients versus the fateful outcomes of structural thinking, the matrix. Okay? So I think we need to sit down and offer these patients the red pill. Okay? We have the red pill or the blue pill. The blue pill represents that biomedical model. And not all patients are ready for the red pill. I had one patient just 2 days ago, came in, arms are crossed, and why are you here, and how can I help you? I like to kind of see what they're going to say. I'm here because I need to appease my physician. I'm like, oh, okay. And we're talking about his pain, and I basically, like you said, you can take a horse to water, but you can't make them drink. I try to, break down those walls a little bit, try to engage the patient, try to validate, but he was not having it. He walked out. I said, well, you can leave if you'd like, and he walked out. Now, that has not happened to me. It's happened to me once in, I think, 7 years. It just happened 2 days ago. I thought that was very ironic. But if if you can offer, like, so I feel like I'm Morpheus in the Matrix, and he offers to provide the truth about their situation, which means waking up from the dream world state, okay? Take the blue pill and go back to where you came from. Take the red pill and see how far down the rabbit hole goes. What I might guess is that many of you guys who are seeing more acute patients aren't quite ready to hear anything about taking a red pill right away, because they're still looking for answers structurally. By the time patients come to me, they're usually pretty desperate for some different answers. So I think I have a little bit of an advantage being a part of a pain management program, but it doesn't mean that you guys can't do it. You just start chipping away. And you're going to sense a lot of failure, I believe, but what I think is that even if it feels like a failure in front of you, you don't see an observable change, something is happening in there. You've had an impact. And I have patients who I didn't feel like I was having an impact until maybe 2-3 year follow-ups. They keep coming back a year later, and they get a little bit more knowledgeable and a little more open about the pain science approach or the biopsychosocial approach. So my typical patient in an HMO, they come in, almost all of them. They're angry, they're frustrated. I'll try not to fall here. They say things like, I don't know why I'm here, just like that gentleman. No one knows what's wrong with me. Everyone thinks I'm crazy, and now I'm starting to think I'm crazy, okay? And I just want to get my life back. And that's what it comes down to. By the time people are coming to see you, they just want to get their life back. They're lost. They don't know what to do. Many of these folks describe going through a complete repeated cycle of having multiple procedures. And I don't know if you guys find this, but over a period of years, they'll say, oh, the injections worked for a while. And now I had a recent injection that helped for 2 days, and the last injection didn't help at all. So that's another sign that maybe there's something a little more less structural on, that the nervous system has become more sensitized. Also what happens is folks, because of the fact that they have the opportunity to go to very many different specialties, is they get frustrated and confused. Each doctor they go to, they get a different answer. So they start to become a victim of what I call the ologies, okay? They've been to neurology, they've been to rheumatology, they've been to endocrinology, been to the chiro, they've been to the ortho, been to the physical therapist, and they're all kind of trying to describe a different structural source for their problem. And of course, if they have many different diagnoses floating in their head, it may create more of a threat to their system, because no one knows what's wrong with me. It must really be bad, right? What else is chronic, how else is, well, I didn't write that correctly, sorry. But what else is another cause for perpetuating chronic pain in traditional health environment? And I think the failure to recognize and address psychosocial flags is huge. The big one being catastrophizing. Those people who say, they go to the worst possible degree. They think that because they had a disc herniation on an MRI that they may not be able to walk in 2 or 3 days or a week or whatever. Or they're very pain avoidant. They're afraid to reproduce their symptoms. And big ones are behavior. Like the patient who comes in, they still have that neck collar on, and they had their whiplash a year ago, okay? So reliance on aids. Those are the folks who tend to cancel a lot or just don't show. Or if they do show up, they say, oh, I had more pain, so I couldn't do the exercises. So they're non-compliant. Emotionally, they're typically very depressed. They're anxious. They may hate their boss. They have work issues. Or they have a very heavy labor job. They may not be that educated. Like I mentioned in the previous slide, they've been given many different diagnoses for their problems, and they've had many different treatments. And a big one, too, is if they're not motivated to get better, because if they stay sick, they may qualify for some disability. So there's a financial incentive to not get well. I try to point that out from the beginning. You realize by doing this, you're setting yourself up for failure. I try to just call it out. It's another barrier for you to get well. So by the time providers, our primary care providers in particular, are starting to recognize patients are coming in with all of these problems, they're like, What do I do? Help me. What's next? Well, send them to pain management, right? My hope is that we can start to stop some of these problems before they get to this point. I think there's a lot of hope in that. But who really gets referred to pain management? For the HMO, the Kaiser that I work for, primarily it's those folks who come in with those red flags that I just described. It's also the squeaky wheel, the people who are continually emailing their doctors or calling them every day, called stalkers. They're stalking me. Frequent flyers at the emergency room or urgent care because they're having a flare-up, they're not sure how to handle it. They have no tools to manage the pain that they're experiencing. The number one reason, escalating medication use. Right now I take a blue pill, a purple pill, an orange pill, a white pill, and a yellow pill, and I need you to prescribe a green pill to complete my collection. It's not too far from the truth here, because they have no other tools to manage their pain. They think, that's just what you do. You go to the doctor, you give me a pill. So really, in order to try to better manage these patients, a lot of the big organizations are now trying to put together a multidisciplinary program to capture these folks and try to give them more active coping tools to manage them themselves. So this is what I do, and this is what we do at Kaiser is we have a multidisciplinary management group, and I wrote the definition there. A multidisciplinary approach involves drawing appropriately from multiple disciplines to redefine problems outside normal boundaries and to reach new solutions based on a new understanding of complex situations, which is what we do. And actually I didn't quite realize this, but there's a difference between multi and inter. So you can have multiple disciplines caring for the same patient, but isn't truly an interdisciplinary care system until these providers work together and communicate together. And that's what we do. Not all programs are the same. I worked in pain management clinics before outside of Kaiser where it's very physician-driven, and there was not communication between the disciplines. It was very heavy in procedures, spinal cord stimulation, injections, and they'd say, hey, send them down to PT to just do exercise, get them moving. And I found that a bit frustrating because I didn't even know who the psychologist was that they were seeing. There was no communication. So I'm very fortunate to now be a part of a team where we share a space. We frequently exchange ideas. Everyone has an equal say in the plan of care. So we're all treated as equals. And we have an electronic medical system, so we can continually communicate through written communication, but can also get on the phone and call these people on a daily basis. With the program that I was describing before, where it was very physician-driven, and I think that many of our treatment approaches are very stepwise, and I think that can be a problem. I was reading something through the IASP task force, and they talked about this, that when you begin with a stepwise process, you don't always figure out what the patient's looking for. So there's some advantage to sitting down with the patient and say, why are you here? What is it that you can't do now that you could do before? And then, hey, I want to be able to go to the zoo with my grandchild. It might be that. Versus going through a full physical exam, oh, you're weak here, you've got poor scapular rotation, and the patient just wants to be able to walk and pick up their child. And spend time with their grandchild. So then you have to be very much more directed in your treatment for that particular purpose. Because if you just kind of go through your automatic pilot mode in terms of care, whether it's massage or physical therapy or physician-based treatment, you lose the patient. And then they just they go on to another provider until they get the right answer. So here's our dream team. We have a number of providers and from varying disciplines, but in order to really just develop a multidisciplinary team, they require to have at least 3 providers. So you need the physician, you need a psychologist, and you need a physical therapist. we're fortunate in our program to also have nurse case manager, okay? And they're really the front lines. They're the ones who I walk into their office and they're just like, oh, this is tough. Because they're kind of the buffer between the physician and the patient. And patients are coming to our program hoping to have less pain, and sometimes it doesn't happen right away. They want just medications to feel better. So the nurse case managers are very helpful in terms of helping develop the plan of care, coming up with a discharge plan, and then also communicating with the patients when they hit these bumps in the road. We also have a pharmacist who is extremely helpful, who helps review their history of medication use, review what the plan is for taking medications, go over what to expect with weaning if they are weaning from a medication, and also what to expect with titrating on a new medication like a membrane stabilizing drug or Neurontin or gabapentin, which can actually be a very helpful adjunct for someone who has a sensitized nervous system and chronic pain. And one half day we have a psychiatrist, which is very helpful as well. The psychiatrist, who's also a physician, will sit in on our multidisciplinary rounds, and we have a number of patients that come in with significant psych comorbidities like schizophrenia, bipolar, depression, anxiety. And so getting their input versus the type of psychological medication and how that will complement their pain can be very helpful. So how does it start? Through our program, what we do is all the patients initially go through the physician. So the physicians play a very important role on setting the tone or the tone for expectations. Patients come in and they're looking for the quick fix, and the physician has to sit down and say, hey, you've done a lot of these other procedures and it's not working, so these are the options. They do a thorough assessment. They review their history. They will give some consideration for injections and medication adjustments because sometimes that's helpful. We have to admit that there usually is a nociceptive process going on in a chronically sensitized patient. So sometimes injections, if they haven't been tried, can be helpful to give them the pain relief just to get them moving. So we work through that. But the main target treatment include the holistic approach. Okay? So the physician refers to the physical therapist. They'll be referred for candidacy for a cognitive behavioral therapy program, pain education, yay, and biofeedback for those folks who really have a very high level of stress in their life. Sometimes these folks do need to be referred out if they come in initially and they have a lot of psych comorbidities. They may not have actually been worked up physically. So there is a time where sometimes we have to refer them back to some of our specialty departments, such as physical medicine, interventional anesthesia, where they're doing injections under fluoroscopy. If they come in and they've got an addiction issue, we usually have to address that first. Particularly if it's a cognitive behavioral or behavioral restructuring program, if they're dealing with active addiction, that's not going to work too well. So we make sure that they're clean for basically 6 months or so before we integrate a behavioral program. Again, sometimes we have to send them to psychiatry. And our women's health, we have pelvic PT, and I think that can be a very useful adjunct for folks who we'll be getting more and more people with just pelvic pain, and they haven't been worked up. Orthopedics, sometimes they need it, and podiatry. And others include rheumatology, neurology, endocrinology. Okay. For the physical therapist, this is what we do. Day one, try to identify some of those yellow flags. Figure out what kind of patient we're working with and how do we need to address those yellow flags. Like I had mentioned earlier, the key here is to foster trust. So we want to really validate their symptoms. And sometimes day one, I don't even put most times I won't put my hands on a patient, particularly if they're super sensitized, stressed. You could just see it on their face. They're ready to run out that door because they've been to physical therapy before. This physical therapist made me 500% worse. And so there's some like post-traumatic stress almost. So We really focus on, I like, in terms of coming up with threes, people tend to remember threes, so I like this one that I made up. First, we relax. We have to relax so that receptive, and they can actually talk. You can try to sneak in the red pill a little bit, educate them. And lastly, try to get them moving. Self-produced movement. And then don't forget, we have to rule out mechanical contributions to pain. Many of these folks, like I had mentioned, may have a nociceptive process going on. So if you can alter their posture, their positioning, and get an immediate relief in pain, you know you're on the right track. So it's a lot to do. We have. Oh. Sorry, Lorimer. So part 2 is the pain psych consult. Sometimes they'll see the psychologist first or the physical therapy first. Sometimes they won't even be willing to see the psychologist, which puts a little more pressure on us as physical therapists. But we can kind of get away with more too because we don't have the title of psychologist. I don't see those people, those psychologists, right? Lorimer, willing to do that, right? So what does the psychologist do? They are looking for those psychological barriers to recovery. And then in that case, that's when they determine, do they need to be sent back to psychiatry? Because if they have significant depression, it's really hard to get them going. No energy, no motivation. They have to determine their candidacy to participate in our cognitive behavioral therapy program, which I'll be talking about. And they try to determine the level of complexity through the proper path of care. So let's go ahead there and look at levels. This is how we do our leveling process. Level 1, I don't see very many level 1 patients. Those are the patients who do quite well on their own. You guys may see them with acute problems. They're the folks who you can give them a few exercises and they just continue to heal well on their own. Natural healer. Level 2 patients are those who are the patients that we're trying to capture the most. They're more recently becoming unstable. They're starting to escalate their medication use. They present with multiple yellow flags that I had described earlier. A few more days off work, and they're just reducing their functionality. They're not as socially engaging with their friends. They're withdrawing. And the level 3s are very similar. Sometimes it's hard to really distinguish between a level 2 and a level 3, but level 3s are the ones with a real obvious psychological dysfunction mostly, okay? They tend to be very passive copers. They may have been disabled for a longer period of time. And we want to stabilize these folks and try to prevent them from escalating further. Sometimes level 3s are good candidates for a program. It just depends on how motivated they are. And then the level 3 plussers, which we do get a fair amount, are the folks who are actively addicted or have significant severe psychiatric components. And we want to just make sure that we take care of these folks because they have pain too, and figure out what would be the right course of treatment for them. Maybe they need to go to a specialty care first. Maybe they need to see the psychiatrist, or maybe they need to see the orthopedic surgeon if they have significant physical issues. Okay. Okay. So the cognitive behavioral therapy program, okay, and rehab. Rehab is physical therapy. It's targeted for our level 2 population like I was talking about. It's usually 12 sessions long. It's 2 times a week for 6 weeks. And we split the curriculum between both the physical therapist and the psychologist. We teach together for that first week to kind of engage patients and kind of develop connections. And then beyond that, for the last 5 weeks, we split our curriculum. The psychologist does basically traditional CBT, the CBT that a lot of research has been done. It's very evidence-based. They help educate the patients about the sympathetic and the parasympathetic process. Many of our patients are not sleeping well, so we say, who's having trouble with sleep? And everybody raises their hand. So we really talk about that early on to try to get them on a sleep schedule and try to eliminate bad habits. They do segments on mindfulness, cognitive restructuring, behavioral modification, so that's the CBT. So looking at how their behavior, their thoughts, and their emotions really affect their pain experience, for positive or negative. Teaching these folks how to pace, although the physical therapist does a fair amount of that as well, using some of the explained pain concepts. Communication, real big issue. Many of our patients, they tend to be very passive or very aggressive, flip back and forth, and we try to teach them how to communicate in a more assertive fashion, so they're communicating better with their providers and their physicians, or any health providers and their family, that's what I'm trying to say. And try to integrate more pleasant activities. These folks, they give up all the fun things, because if they particularly have a good day, I'm having a good day, I need to clean out my closet, or I need to get to the grocery, or I need, do the basics of necessities of life. And part of that healing process, I really think it's important for them to learn how to have fun again, because they've given that up. And try to release those natural pain, medicine in their brain. And goal planning, very important. Many of these folks don't have any goals. They've just been living day to day for years, and you ask them about their goals and they kind of give you a blank stare. What do you mean goals? I'm disabled. I'm a chronic pain patient. I have no life, right? So trying to just kind of re-engage them in hey, life is a blessing. We can do things here. The physical therapy curriculum for the CBTR class has been kind of a fun process for myself and my colleague. I've been doing this now for 3 years, and every year I change it a little bit. And from the beginning to now, I've included a lot more pain education. So day one, I get them going, first session. And I do share a lot of what I have learned from some of the greats like Lorimer Mosley and David Butler and Adrienne Lowe, try to sneak it in from the beginning. But I tend to be very careful with how I use my terminology and wording, because on day one, if you mention the brain, whoo, they get very threatened by that. So I talk about the nervous system and that there may have been changes in the nervous system. And then slowly but surely, we kind of get into the fact that this is what's going on here. DIMS and SIMS, thought I would throw that in there. Just learned that today, but I'm going to start integrating that next week. I think it's wonderful. So, and challenging biomedical thinking. When from Canada, there was a poster that one of my coworkers came up with, and I think he learned about this at the Adrienne Lowe conference, and called "Vomit: Don't Be a Victim of Imaging Medical Technology." Okay. And it's a marvelous poster because it's something that you can put up on your wall, and it has all the different body parts listed, and with each there's a little bit of evidence showing that, hey, structure's not always tied to your pain. And in fact, many people have structural abnormalities without pain. So and they don't believe it if you tell them. But if it's up on the wall, it looks a lot more official, a little more receptive. And what I love to do is I have all the posters, explain pain posters, and the vomit poster on my wall. I'll just leave for a while. Patients will get up, and I just like to walk in and see, are they reading the posters or what are they thinking? And I say, oh, did you see that poster? And then you question them, just kind of see, what are they thinking? Where are they right now? And then about halfway through the sessions, we'll do a knowledge check, which I really love. I give them the questionnaire, it's kind of homework, and then they come back and we go through the questions together. And that really gives me a good idea of where they are. It's amazing some folks don't get it at all. So, and other folks in the class do get it, and so they kind of communicate together. So it's nice that they can kind of work as a group to try to problem solve what this pain knowledge is about. And then in order to get patients to really follow through with things, I think really they need to understand why they are doing things. And so I spend a lot of time educating folks on why do we need to relax? Why do we need to combat that fight or flight system? And actually what physiologically happens when you're not relaxed, and how that can contribute to their pain experience. So we talk about the benefits of relaxation. I talk about and repeat some of the research studies that show that learning about the physiology of pain can desensitize the nervous system and reduce pain, decrease disability, pain avoidance, and talk about the benefit of just movement. I just love a lot of the terms that I've learned from both Butler and Mosley, like motion is lotion, right? The best movement is your next movement, okay? Start low, go slow. Patients really get that. Don't panic. I made that one up. Panic. Empower self-efficacy. So we focus a little bit on just the basics of body mechanics, ergonomics, posture. I always emphasize that the best posture, in general, okay, is the one that changes frequently, because I'm really trying to get them to move. Because they have it in their mind that they have this picture, this ergonomic picture, they've got to be like this for 8 hours. But I have great posture, and I had an ergonomics person come in and set up my chair correctly, and no, you need to get up and move. Move. Self-management tools, those would be the things that can kind of close that pain gate, such as like simple things, ice pack, heat pack, TENS unit. Pain patients, they forget about that stuff. It still will close that pain gate. It can be just a number of little things that will help reduce their pain levels. Many of the folks that come in, on average, they're between a 5 and a 7, pain-wise. And I say, all these little things, whether it's a self-management tool or a particular movement or an education, in general, you should expect your pain to come down 2 to 3 points. So give them reasonable expectations, because they say if I'm not a 0, it's not a success. So you kind of give an idea of what can they expect. And I say over time, what you'll find is that you'll be able to do more before you really feel better. And then when you start doing more, then you're going to start to feel better. Give them an activity plan. Lay out a schematic. Give them options for movement with real emphasis on doing cardiovascular. Want to get that heart rate going. And flare-up management plan. Towards the end of the sessions, we say, okay, you've got all these tools. You're going to forget them all when you're flared up. It's just going to go out the window. So we really work on trying to get like a little, maybe a cookbook box, a recipe box. I say each card, make a different tool that works for you. Could be breathing. Could be a certain movement, something that works for you. Everyone's individual. With the activity plan, I really put a lot of emphasis on establishing a baseline and exposing yourself gradually. These folks tend to really boom and bust and flare up, so I'll talk about that in just a moment. Okay. And in terms of the actual class, movement participation, each session I get them moving. I do educating, I do a lot of talking, but half the time they're moving. They have to move. So we integrate a little bit of cardio, and in an HMO environment, I don't have a lot of contact with these patients, and so I try to give them a lot of tools. This is a wonderful video on the YouTube. You can find it, you can get it at home. You could be in your home at your computer and watch this. We could do, yoga posture. So I really emphasize from the beginning, breathing with movement. Simple, just yoga movements. Stretching, how to stretch. And I just give them ideas that you have to listen to your body. Strengthening, some of the benefits of that, and I try to be very functional. What is it that you can't do? What are we going to work on? Awareness through movement, okay? I do tease a little bit, I do expose them to a little bit of Feldenkrais. Now, I'm not a Feldenkrais certified therapist, but I love a lot of the exercises and movements, so I try to kind of introduce that into their system. They tend to respond very well to that. And then I introduce them to Tai Chi through some YouTube videos, because I'm not Tai Chi certified, but I do want to make sure they have the opportunity to see what's out there. Some of the additional components that we've recently added to our CBTR program is laughter yoga, and a lecture. Any laughter, certified laughter therapists here? All right, right on, great. Our nurse case manager, she's a certified laughter therapist, and the patients love it. Now, we don't do it day one, because they're gonna be like, oh, this is way too weird. There's no way I'm gonna participate in laughter therapy. So we tend to integrate it more towards the end of the sessions, maybe session 11, and they know each other and they're feeling a little more comfortable. And the lecture is very helpful because they describe some of the actual research behind why laughter can be helpful for pain. The pharmacist comes in and does a lecture. The patients love the pill talk. They just love to talk about the drugs. And so he does a very good job of just describing the different classes of medication. He doesn't say one's better than the other. He describes that. The main focus is that you have to have a multimodal approach to your pain management. So it's really quite good. And he does basically say what I had said before. A medication may help bring your pain level down 1 point. Movement, breathing, relaxing, bringing down another few points. Okay. Kind of multimodal. And then we do a little bit on nutritional concepts. So, because I think that's a very important part. Patients always want to know about anti-inflammatory. And I really kind of actually have a struggle with this topic because I think there's not a lot of evidence behind some of the anti-inflammatory. The evidence is all over the place when it comes to nutrition. So a lot of it's more behavioral guidelines and kind of going, I'm not the psychologist, but the psychologist will talk about, what is our motivation to eat, when we don't eat healthy, why is that? Are we trying to cope in unuseful ways, maladaptive ways? CBTR outcome measures. Our psychologists do collect data, and they look at function. They use the Oswestry Disability Index, and they do the outcomes prior to beginning cognitive behavioral therapy and rehab and on the last day. And I have some data that shows over, I think over 1 year period of time. They did some t-tests through the SPSS program, and they found that with the t-test there was a significant difference, including the p-values, and there was a positive effect using d-values, effect size. There were mean differences even accounting for the measurement and the error. Okay. So I have here just a little bit of a showing that that Oswestry Disability Index shows that there was a decrease there from pre to post. And Oswestry Disability Index is a good measure of function and how they're getting through their daily living. Beck's anxiety inventory as well also looks at anxiety, shows a decrease. The depression, decrease. Many of our patients come in very depressed. At the end, there's like a light in their eyes that they haven't had in years. It's very encouraging. And the Cohen's D, it should be above a 0.8 to have a very large effect size, and all those three measures did have a Cohen's D greater than a 0.8, which is great. We also I like to try to jot down some of their subjective comments when they fill out their outcomes questionnaires. It can be quite telling what the patient's thinking. And some examples I have listed here. It's not a quick program, but a process and a long-term solution to a long-term problem. Yay, they're getting it. I changed how I interpret pain. Perfect. This class saved my life, and I'm finally feeling hopeful again. That's what makes me come to work every day, is when I can sit down with a patient and they're just like, they are so down and they're just so frustrated and they're defeated. And I start to give them a little bit of that red pill, that pain education, and they're kind of like scratching their heads and they're a little receptive and saying, I've never heard this before, which is a problem, right? By the time they get to me, they should have heard this. And they walk out and say, wow, this is different, Cara. This is the first time I've ever had hope. I'm feeling hopeful for the first time in years. And they have a little bit of spring in their step when they walk out of the office, and it just makes me feel great. I think that we all can have that impact. Once our folks have graduated from the program, if they've attended at least 7 of the 12 sessions, they officially become graduates of our program, okay? And they have the option to follow up with us forever, basically. We have a free, what we call Maintain the Gains class. It's once a month, and we teach in different areas of San Diego County. And it's taught by both the psychologist and the physical therapist together, which I like. And it gives us an option to kind of introduce new topics and review old CBT topics. I really like it as part of my area to kind of try some new methods of pain education. It's also interactive, so patients do have the opportunity to kind of express what's going on, whether it's positive or negative, in the group setting. Future, what we're working on trying to develop, which I think patients have been asking about this for a while, we're working on doing this, is developing a class for those who, for family members of patients who have been in the CBTR program. Because what we have found through our observation is that a lot of folks go through the program and they've learned to identify maladaptive thinking and behavior, and then they go home and their family members don't know that. So they can fall right back into their old patterns of kind of enabling the patient instead of supporting the patient in an appropriate manner. So we hope to put a class together to help educate family members and friends as well. And one of the things that my passion is I want to teach everybody about pain. Let's do it. So I have started a one-time class, Explain Pain class or Therapeutic Neuroscience Education class, and it can be offered prior to the patients participating in cognitive behavioral therapy, or just for folks who can't participate maybe because they're working. They don't want to miss work for the 6-week class. And this class, I do say, hey, bring a friend, bring a family member. The more the merrier. We want to teach everyone. Pain is another sense in your body. You should be a real expert in this area. It's kind of like being a diabetic. If you have a chronic pain like diabetes or a chronic problem like diabetes, you don't go to the doctor every time your blood sugars are off, right? That would be a real pull on the medical system. Chronic pain is the same way. We have to figure out how to manage this. What's happening in the very near future, too, is we're starting to have a presence in our primary care module. So we're working with primary care physicians, pretty exciting. And so my hope is that we can really catch these patients early on. So if they present with yellow flags but with an acute or subacute problem and they're showing up in the primary care physician's office, primary care doctor, or the physical therapist, we'll send them right over to the Therapeutic Neuroscience Education class. Woo! Almost done. Woo! So a lot of you guys are thinking, oh, this is great, Cara. This is very interesting. I don't have that available. I don't have a whole team. But team of one, you can still do it, okay? And you guys are going to learn. You have learned some from Jason, and you've learned some from Lorimer Mosley, and you'll continue to learn through this weekend that the key here is that you can do it as an individual. And the key here is making connections with these patients. Having reasonable expectations is really important. I do get a lot of feedback from my patients who have been traditional physical therapy, which shouldn't be traditional physical therapy, we should all be treating the same way, in my opinion, that they were taught, they flared me up. They just had me do too many. So I think it's important to realize that if you see someone with yellow flags, they have spreading pain, the pain has a mind of their own, there's no necessary predictable aggravating and easing factors. These are some of the clues that the patient has a sensitized nervous system. You're going to have to treat that patient a little bit differently. Not like the typical 3 sets of 20. Because they'll never come back. Because you're going to ruin them. You're going to flare them up. And again, that creates more sensitization. Another thing, start with the end. What is that patient's goal? Why are they there? Not why do you think they're there? Why are they there? And evaluate the patient behaviorally as well as structurally. We're not psychologists, but I think it's very important to kind of ask them a few questions, try to determine what is their personality like, and that may help determine the direction of care. Examples would be, are they what we call boom bust patients, right? They tend to just blast through and then they're down for 3 or 4 days. Super common. Or they're the pain avoidant patients who they just are afraid of reproducing any pain at all. That would be a different type of program between those two patients. With the boom bust patient, you have to do a little bit more educating as to why that's not going to be a useful strategy in the long term. For pain avoidant, same way, but you explain it differently. If you're not moving, you're not getting blood flow, you're not getting circulation to your body, and you're getting weaker, your posture is changing, and that creates less, more adaptive movement. May potentially be creating more pain. What else? Concrete thinkers, like the one I described. Are we ready? Okay. And those folks who don't want the red pill. And lastly, we want to just empower those patients. Put them in the front seat of the car, let them drive, put the pain in the trunk, and that's the key. So solution summary is the patients need validation, build their trust, begin pain education early, recruit specialty help as needed, establish patient goals together. The pain disability cycle must stop. And that's it, I'm done.
Cara, wonderful, thank you.
Thank you.
So we will have a few minutes. We did get started a little bit late. We did go a little bit late on that. So we're going to only have about 10 minutes or so for questions. If you have a question, please put your hand up. We do have a gentleman back here. So Lee is on the way with the, Nikki Lee is on the way with the microphone.
Hi, Kara, excellent talk. I think your talk kind of hit on one of the issues that I've seen working in a similar setting, in that this balancing of hope, but a realistic appraisal that, sometimes the experience of pain doesn't necessarily go away. And how do we balance that in some of the conversations that we have with patients? Because I think it's, sometimes we can be a little too hopeful, and that kind of blinds sometimes, or it overpowers the idea that the evidence shows that we can continue to experience pain for long periods of time. Maybe.
I think that this is where the cognitive behavioral therapy portion can be quite helpful, because the psychologist primarily will describe, and we can do this too, is if you're not a psychologist, we can all as providers do this, is describe that pain may be there, but it doesn't necessarily have to rule our lives. We have two kind of meters, okay? We have the emotional meter and we have the pain meter. And to know that you can actually spend time with your grandchildren, or you can go to the park, or you can spend time with your friends, and you may still be in pain, but doesn't necessarily mean that you have to be terribly unhappy at that moment. And then over time, by them integrating themselves into society, eventually, the hope is that the pain will become a little less of a dominant feature in their lives, move differently. Maybe we're changing neurotags there. It's difficult, because I do get a number of patients who come in and say, I'm still in pain. But there's a certain level of acceptance that they go through, and sometimes they, even though they're still feeling the pain, I still give them the hope that if they continue to pace and gradually expose themselves to activity, that pain levels will eventually come down. And just try to emphasize the positive aspects of what has changed in their thinking. Did I answer your question? No.
We have a question up here in the front.
Yep.
And while Nikki is on the way with the microphone, one quick question.
Oh, yeah.
So if you are working in a healthcare facility where the team is not familiar with biopsychosocial concepts, how do you introduce that?
That's a great question. And I don't know if I have an easy answer for that. One thing that what we are starting to do is go through, and I do basically a explain pain or pain education course for clinicians, and introduce the difference between structure and biopsychosocial, and illustrate the benefits of maybe trying to integrate more of a biopsychosocial approach. And we've been pretty well received with that. And also catching some of these physicians early too. We're starting to work with primary care residents. They get to shadow our department and try to get them young and early, teach them about the biopsychosocial approach. Yeah.
Thank you. All right, we had a question right here. No, in the front row here. Yes, and you'll be the last one.
Hi, Stephanie. The Mosley Pain Knowledge Questionnaire is, do you use that for a measure of change over time? Is there a significance number on that?
It's more of an exercise. I don't use it to collect data. I don't give patients the pressure, oh, you need to turn this in, because I'm not actually trying to collect data and perform a study based on that response. But I use it as kind of a tool for conversation and a tool for problem solving.
Is there a number that's good or bad?
I think 100% is good.
Okay.
But I don't know actually the metrics on what would be considered maybe.
Significant change, okay.
Yeah.
Okay.
Thank you for a good presentation.
Thank you.
Actually, I have 3 questions. Is that allowed?
Are they short? We'll see
Well,
how the first one goes.
Oh, let's see. The first 2 is, what do you think about calling it pain management? With our current knowledge, is that problematic or is that fine?
You hit on a good point, because our department is called pain management. And so that's what I call it in my presentation. But when I'm in front of patients and I'm describing that you're here in pain management, but we are here to try to treat. I don't like that term. I don't think patients want to hear that their pain is being managed. Like, I'm managing my pain right now. I'm still in pain and I'm managing it, right? So without trying to give too much of a false hope, I think there's really hope that we can treat your pain, but it will take time, and you have to be persistent with following through with your care. Exposing yourself gradually to things, pacing yourself.
You talked about posture a few times, and I find it problematic because people have a tendency to consider the right posture, the wrong posture. As you said, it's move, but I didn't really get, where do you stand on posture? Do you believe there can be faulty posture, bad posture, or what? I didn't catch exactly what you meant.
I think that's a touchy subject, I think, for a lot of folks. I think newer evidence to show that having perfect alignment is not necessarily the best thing. You know, everyone's different. Everyone's built differently, in my opinion. This is opinion, so let's just say that. And I make a point, day 2 or 3 of the session, is that I would like to see you guys move frequently. Sit like this, cross one leg, cross the other leg. Put a stool under your feet, put something underneath your arms. You know, get up frequently. I want to see people moving. I don't think we're meant to sit 8 hours a day. I think it's very detrimental to our health. And so if they can't get up, I say you just need to shift and move as often as you can.
Totally agree. But you just mentioned it, perfect alignment. What is perfect alignment? We need to be able to, yeah. Well,
Right,
you know.
right.
So,
It depends on who you're talking to, I
yeah.
suppose.
Okay, so
I'm not even going to go on that.
could you elaborate on your flare management plan?
Oh, and then,
No, you go ahead.
okay, should I answer this one?
Yes, you can.
Okay. So flare management plan. So the key here, this last one, whoosh, we want them to be able to stop the bullets on their own a little bit. So flare-up management go from anything from trying to, if you didn't pace, learn from that experience, maybe keep a pain log and see what were you doing that caused the flare. Educate the patients that maybe you would flare up without any reason at all, and to not panic about that. Okay? So behaviorally and thoughtfully, how do you react to your flare-up? And then talk about some of the physical management of pain, whether you're using ice pack, heat pack, repositioning yourself so that you're comfortable, trying to breathe and relax and calm and soothe the nervous system. That's a real big emphasis for me is that day one I say, your system is feeling way over-threatened, so we need to work on calming and soothing the nervous system.
Would you
So it's a
show
good
us
step.
that movement you showed me last night?
I don't remember what. Oh, the yoga, yes. Well, you know, just day one, you guys can all do this. You should all stand up because we all need a break. It's just standing up. And it's very simple. I think Neil Pearson will have better things for you guys, right? But just take it. We start with a big belly breath, breathing in. Exhale. And now raise your arms up, breathing in. And then exhale, let the arms come down. I call this my Michael Phelps move. Inhale up. And gently rotate to one side. Inhale up. Rotate to the other side. Wake up, stretch, hands, fingertips on the shoulders. Inhale, elbows back. Exhale, elbows together. Inhale. And exhale. And relax. So we do more than that, but honestly, I think most patients can handle that one. So it's very non-threatening. It's getting the patients moving. It's getting them breathing. So it's usually where I start for the patients who are not handling much.
Cara, thank you very much.
You're welcome.
This would be a good time.
Thank you. Thanks.